Mi nombre es Susana y yo soy una miembro, ¿verdad?, de lo que viene siendo la comisión de NAACP.
And we're really glad that you're here. Thanks for coming.
Y estamos muy entusiasmados de que están aquí el día de hoy.
Just a couple things before we start.
Bueno, un par de cosas antes de que comencemos.
We want to do a survey at the end of this series, and that the last session is next week, August 27.
Queremos hacer una encuesta y en la última sesión va a ser agosto 27.
And we will send that out by email.
Vamos a estar mandando estos por correo electrónico.
If you registered for the webinar, we have your email address.
Si acaso ya se había registrado para ese seminario web, ya tenemos su correo electrónico.
But if you signed up through a link, if you entered the webinar through a link from a friend or a colleague, we don't have your email address.
Pero si acaso nos está acompañando en el seminario web por medio de alguna cuenta de algún colega o algún amigo, entonces no tendremos su correo electrónico.
If that's true for you, please give me your email address so we can send you the survey.
Si acaso este es el caso, por favor, comparta su correo electrónico para mandarle la encuesta.
You can put it in the chat directly to me. Find my name in the participant list, Susan.
Puede usted ponerlo, ¿verdad? Su correo electrónico directamente en la lista de participantes. Puede encontrar mi nombre, Susan.
We're recording the webinar, as you noticed. We turned the recording on.
Como ya se dio cuenta, este seminario web está siendo grabado.
And that is so we can widen the access to this content to other people after this series is ended.
Y esto es para que podamos abarcar un poco más aún después de que estas series hayan terminado.
In the recordings, we show only the slides, the moderator, and the presenters.
En las diapositivas solamente miramos a los presentadores, a los moderadores y también who was the other one? Sorry, Susan.
The presenters.
Los presentadores, sorry.
For your privacy, none of the participants will show up in the recording.
Para privacidad, ninguno de los participantes va a salir en la grabación.
We are offering Spanish interpretation during the webinar.
Estamos ofreciendo interpretación en español durante el seminario web.
On a special language channel.
Y esto es en un canal de lenguaje especial.
For anyone who wants this, you can access the language channel by clicking on the globe at the bottom of your screen.
Para aquellos que deseen utilizarlo, pueden seleccionar el globo o el icono del globo abajo interpretación.
Choose Spanish.
Selecciona español.
And then choose the text that says mute original audio.
Y por favor, asegúrese de silenciar el audio original.
On a cell phone or other device, it looks like this. Mark, will you move to the next slide?
En un teléfono celular o algún otro dispositivo móvil se miraría de esta manera.
Click on the menu at the bottom of the screen.
Hace clic en la parte de abajo del menú de la pantalla.
And choose language interpretation.
Y escoge interpretación del lenguaje.
Because we have simultaneous interpretation in the language channel.
Por causa de que tenemos interpretación simultánea en los canales de lenguaje.
Our presenters are going to pay attention to the pacing when they speak.
Los presentadores van a estar prestando atención de la velocidad o la fluidez al tiempo de hablar.
We will speak more slowly, like I'm doing, with more pauses.
Vamos a hablar un poco más lento, como lo estoy haciendo ahorita, con más pausas.
when we have the discussion time, we would ask you to speak like that too. It makes it easier for the interpretation.
Ya que llegue el tiempo, ¿verdad? Cuando se le permite dar su comentario o sea parte de la conversación que tengamos, entonces le pedimos que haga lo mismo para ayudar con la interpretación.
Thank you. And I'm going to turn on the interpretation now.
Bueno, muchas gracias. Voy a ahora encender interpretación.
And well, I'm sorry, it's already on. And we're going to start the recording, the Spanish recording.
Bueno, ya está entonces, está accesible, así que vamos a empezar la grabación en español.
Thank you. And now over to you, Mark.
Gracias. Ahora le pasamos el lugar a Mark.
Good morning. You are participating in the second part of the NAACP series, 6 webinars, of which we are in number 5, Saturdays on Zoom, 10 to 11:30 Pacific Daylight Time. The overview, the first seminar was Your Rights to Excellent Health and Healthcare. June 25th, Communicating with Providers. July 16th, Selecting and Working with Healthcare Providers. August 6th, Feeling Safe and Valued as an Individual within the Patient-Provider Relationship, Trauma-Informed Care. This seminar will be, the topic will be Managing Mental Health. And our last webinar, a community conversation, what we learned presenting this and including resources and strategies going forward. The webinar format will be giving a presentation from a mental health professional. We will have followed by a patient panel and discussion among participants. We plan to summarize lessons learned from each session and develop a webinar for providers to help them to respond to things that you need. No names or identifying information will be in these summaries. As always, a $15 gift card will be given to 3 attendees chosen at random, and they will be chosen during the webinar and announced at the end. Today's webinar, August 20th, Managing Mental Health, Your Rights as a Patient to Choose a Mental Health Provider, mental health resources, including suicide prevention resources, broadening our definition of self-care, managing mental health with or without medication, choosing your own treatment plan. I'm your moderator, Mark Harris. Our presenter today will be Dr. Ali Revelis, a licensed psychotherapist, and our patient panel, TC Dumas, Julie Carter, Amy Lovell, a retired pharmacist. So, by way of introduction, my degree, my master's in a Master of Arts in Psychology. I come from a Black psychological family. What I mean by that, when I explain to my students and clients, Black psychology believes racism exists. It can be cataloged and treated. That is not the belief of mainstream American Psychological Association. So historically speaking, in the 20th century and the 21st century, when the first doctors, lawyers, and other people of color got trained, trained in a context where the racism that was historically talked about was not part of our education. And we often had to endure discrimination when we tried to suggest that certain practices might be questionable. This is from a book, part of my training, Self-Advocacy. In its long and ugly history in the United States, white racism has improvised 1,000 variations on two basic themes. One, Black people and other people of color are born with inferior brains and a limited capacity for growth. Two, their personality tends to be abnormal, meaning whites are normal, whether by nature or by nurture. So this is true from the beginning of the American Psychological Association and the mental health system in this country. These concepts of inferiority and pathology are interrelated and reinforce each other. Both have served to sanctify a hierarchical social order in which, quote, the Negro's place, unquote, is forever ordained by his genes and the accumulated disabilities of his past. This is from Racism and Psychology, a book by Alexander Thomas, psychiatrist, and Samuel Sillin, PhD. So health consequences. Black mental health was associated with compliance to racism. So for example, slaves were considered mentally ill for running away from slavery. They actually created a term for this, drapetomania aegypticus, the flight from home malady. Samuel Cartwright, who coined that phrase, was a mentee of Benjamin Rush, a signer of the Constitution and a slave owner who actually believed that Black people could be placed in the way of smallpox, absorb all the smallpox so that the whites would be free of it, founding father. And he is considered the mentor of the founder of this American Psychological Association. So angry civil rights advocates in the 21st century and 20th century were to be treated with major tranquilizers like Haldol. When Black people are correctly diagnosed with any disease, it is usually at a later state more difficult to treat than whites if it gets treated at all. They are disbelieved and under-medicated for pain, over-medicated for racial trauma or hypervigilance to avoid racial trauma. Mental illness caused by racial assaults or witnessing traumatic events is misdiagnosed as something else, and societal or professional racism is denied. So part of that research, Judy Katz, a researcher and educator, in her book, White Awareness, Handbook for Anti-Racism Training, published in the mid-80s, identified racism as a disease, a critical, pervasive form of mental illness. People like Einstein and other Black, and a physicist, anti-racist activists, identified racism as a disease in 1954. Black professionals followed suit and began expanding on that idea. But Judy Katz talked about it's not a new idea, but racism is a disease where society is the agent of spreading that disease rather than the pathogen itself. Racism has all the classic elements of destructive behavior, including acting out, denial of reality, projection, of your problems onto somebody else, blaming someone else, transference of blame, disassociation, and justification, all classic symptoms mentioned in DSM-5 as schizophrenia and psychosis. One way this disease manifests is through the delusion of white superiority. And the author cites 6 studies dated from 1968 to 1972 in a book published in 1985. The delusion of white superiority manifests itself as arrogance coupled with a disdain for everything that is non-white. This is perpetuated by deliberate omission, falsification, and emphasis, leading to a belief that everything great, including the science, all valid science regarding mental health, was done by the work of whites. So many helpful constructs from Black psychology and the efforts of people to begin to define ethnic identity dysphoria, just like gender identity dysphoria, racism as a disease, like alcoholism, racism as a co-occurring disorder, that means many races commit acts of racial terrorism under the influence of substances. So mental illness is amplified by substance use disorders. Racism as a pandemic, like a mimetic viral pathogen. Racism as a public health problem. So many of these concepts date back 70 years, but we only have begun paying attention to them in the public sphere fairly recently. One of the most ancient concepts that is in the 1800s, Frederick Douglass created the idea of addiction as slavery. So as much a part of the economy and the normal infrastructure, normal if you will, of society and the economy, like chattel slavery was, supported by laws and the prison industrial complex, the new Jim Crow. So given this context, racial and personal trauma must be dealt with, whether or not the mainstream society and its institutions deal with it. So it's not what's wrong with you or me, it's what happened to me that must be addressed. That was a mouthful and a mindful. So, Allie, take it away.
Thank you, Mark. Good morning, everybody. Buenos dias. My name is Dr. Allie Revelis. I'm a licensed psychologist here in the area. I am going to I think I'm going to keep the soothing rhythm breathing for the end, and just because I want to make sure we have time for our panel. So hopefully we'll have time to get to that. But Mark, can you move me on to the next slide? So I presented back on July 16th about how to select a healthcare provider. So for those of you who attended that session, I'm sorry if some of this is repeat, but I wanted to sort of touch on how we get started with our mental health care. And one of the places I wanted to start was making sure that people know what their patient rights in mental health care are. So you have a right to know, what your diagnosis is. I am very open with my clients about what diagnoses I'm giving them and why. You are allowed to know what your therapist includes in their notes and what's included in your medical record. You have a right to know what your treatment plan is and what the estimated length of treatment is, as well as costs associated with that, right? It should not be you being in the dark, being treated for your mental health, and sort of not knowing what's going on. One thing, and I apologize to the interpreters because I realized I was speaking fast. One thing I didn't include was also that you have a right to interpretation services in mental health care and in your typical medical care. If you cannot find a provider who speaks the same language as you, there are structures available for us healthcare providers to make sure that you are still able to get care, even if we can't provide that care in your native language, right? So most clinics have an interpretation service that they use that is available for any time that you need it. So this is where things might be repeated from the July 16th webinar, but choosing a therapist can feel daunting sometimes, right? Knowing where to start can be hard, and it's hard right now given the capacity that many therapists and therapy offices are at. Most of us are over capacity, but there are places that you can go to find somebody who might be a good match for you. Those include therapist directories. One very popular therapist directory is found on Psychology Today, and you can just type that in, psychologytoday.com. It'll bring you to the website, and you can search for therapists based on your location, based on specialties or concerns that you're wanting to work on. They also include insurances that different providers cover. So that's a great place to start. Typically, your insurance provider will have a search option for finding providers. That's another way you can potentially find a therapist that's in network with your insurance company. And then while you're looking for a provider, I think it's helpful to know that there are a lot of different types of therapy to address many different concerns. There's solution-focused therapy, which is typically short-term. You're working on sort of one big issue in your life, and that therapist is helping you find solutions for that problem. I know some therapists who limit sessions at like 8 sessions for that. So then there are also longer term options, right? Some folks practice cognitive behavioral therapy. There are also special variations of different types of therapy. So I included trauma-focused cognitive behavioral therapy. The type of therapy I provide is called relational cultural therapy. So that's sort of more long-term if my clients so choose. And I focus on different issues, including the way that the world around us is impacting our distress and increasing or decreasing it, right? We don't live in a vacuum. Most of us, unfortunately, do not live in a bubble. So we're impacted by everything that's happening socially, politically, economically, environmentally. I like to take all of those things into account when I'm working with my clients. Something else folks may not know is that a lot of therapists offer an initial consultation prior to even a first session, prior to that intake session. I do that oftentimes with clients to make sure that I'm going to be able to address the concerns they're coming in for. I would rather not waste somebody's time. It can be really nerve-wracking to meet with a therapist for the first time and sort of share all of your personal history. So I want to make my process the least invasive as possible and make sure I'll be able to address whatever concerns people are coming in with before I make them sort of open those floodgates, right? And then say, oh, sorry, I don't think I can work with this issue. So many times, even if not advertised sort of on a therapist directory, if you call an office and ask for a consultation, most therapists are very happy to do that. Okay, Mark, next slide, please. I also wanted to talk a little bit about mental health crises, right? Specifically suicidality, because suicide has become an issue for our local community and I think for our country at large. In recent years, rates are increasing, unfortunately. Being able to talk with loved ones or folks you're concerned about is incredibly helpful as a first step. The most helpful way to talk about suicidality is asking directly, which often feels counterintuitive. Most people worry, if I talk about suicide openly, is that going to give somebody the idea to go and take their own life? But what we find in the research is no, that often opens up space for a person to be able to talk about what their struggles are. So I've included here some local resources to the Eugene-Springfield area, including Whitebird Clinic. They have a crisis hotline that's 24 hours a day. The Cahoots Crisis Response Team, and I am going to give a caveat with that. So the Crisis Response Team also goes to the police non-emergency number. Often there will be officers who go out with the crisis team to respond to different calls. And I think this is important for folks to know, especially people of color, Black communities, communities of color, because the police presence does not always help in those situations. So if you need it, call them, use that resource, and know that there will probably be an officer responding, and that could potentially escalate whatever situation you're in, especially given what we know about treatment of people of color, Black people especially, from the police. There's also a really great website, the Suicide Prevention Coalition of Lane County. I've included that link here, and I will include all of these resources on a sheet for our final webinar session so that you all have easy access to it. That website has a lot of great information, so I recommend checking it out. I've also included some national resources. Recently, the National Suicide Lifeline, the Suicide Prevention Lifeline, got a very simple national number. We now are able to dial 988 to get connected right with that lifeline. So you or your loved one has somebody to talk with through those difficult moments. They also have a text line if talking on the phone is too nerve-wracking. And I've included a special suicide hotline for LGBTQ folks, because we often face different issues than our straight peers. Okay, Mark, I'm ready for the next. So the last thing I want to touch briefly on before we get to our panel is self-care. So often when folks hear the term self-care, it's an automatic, well, I don't have time for that. I don't have the resources for that. We might think, pampering yourself by getting a massage, that's self-care. But I really encourage us to think more broadly about what self-care can be and what it encompasses. For example, today I am actually visiting a friend for the weekend. So I'm in her house doing this webinar, but that's one way I'm engaging self-care, right? Which is especially important for those of us who are providers so that we can give the best care to you all, our clients. And this sort of piggybacking with what Mark was talking about, understanding that it is reasonable to be outraged at outrageous things, right? So, being pathologized for having a normal response to something very upsetting happens frequently to Black people and people of color. But it's really important to honor our anger and sadness, and doing so is a form of self-care. Engaging with our loved ones and our communities is also self-care. So I hope some of, the attendance today, I hope you all joining, I hope some of that feels like self-care, right? You're taking a very proactive approach in taking care of yourself by learning how to do that better. Hopefully getting connected with some community members. I'm not sure if any other folks are going to the Black Cultural Festival today. That's an excellent way to get in touch with our communities. I'm sharing here a screenshot of a toolkit created by some Latinx psychologists from Chicago, really developed after the 2016 presidential election to help people of color deal with some of the extra stressors that we faced after that. And they start with caring for our physical health, right? Making sure we're eating, sleeping, all of those basics are the foundation we need for self-care. It also talks about sort of staying connected with our communities as another form of self-care, right? And I'll also include this handout in the resources I include for the final webinar. And just before we go here, you know, something that I have learned as a Latina psychologist when trying to get back in touch with my native culture, right, my Mexican roots, you know, we think about therapy as maybe coming from Europe or European people, when really, you know, in ancient Aztec culture, there were people called Tonopalki who were basically talk therapists. Like talk therapy existed in Aztec culture. So being able to take care of our mental health is really an ancestral sort of priority, right? And I don't think many of us coming from communities of color realize that this work actually is our work. And I haven't investigated or researched what mental health care looked like in, you know, different African communities or cultures, but I'm sure it was there too, right? So remembering that too, I hope that helps empower folks and make them feel like they can take care of our mental health care, because of course there's still a lot of stigma attached to mental health care and how we manage that. Okay, I think we are ready to move on to the panel because that was my last slide.
Thank you, Ellie. TC, Julie,
Yes.
Amy, unmute yourselves. Do you want to go in order when I ask the questions? Well, yeah, let's do that. TC,
Yes.
tell us your story.
Well, my story, and I'll talk about that and how managing my mental health related to managing my mental health. When I was 13, my mother sent me to a psychologist or a psychiatrist. I don't know what the person was. And that person told my mother that I was normal. But to me, it translated as, I mean, I never thought of myself as normal again. I thought something was wrong with me. My brothers laughed at me because I was the only one that was taken to a psychologist or whoever the person was. And so that stuck with me. And I didn't know that my mother didn't know, though, when she sent me, that I had multiple traumas that impacted me, you know, at home and at school, church and neighborhood and all that. And so she wasn't aware of that. So there was something wrong, but it wasn't with me. But I thought it was with me because that was, you know, by being singled out to go to the psychiatrist. And so anyway, I continued my life. And at 18, I tried to take my life. So I was hospitalized, and that began the series of me being in the mental health system until today. I guess that I was, my mental health was managed by me until just more recent years. I'm not managed by me, I'm sorry. It was managed by others until more recent years. I was, you know, like forced to take medications. I was not given a choice about, you know, even, you know, very simple things, where to live in some ways. And I was given electroshock treatments. I was given medications that dulled my senses, and I was locked in seclusion many times for days at a time. And so those things further impacted, and, you know, my ability to to take care of my own mental health, because that I was being managed and my mental health was managed. And so I'll fast forward to later years, which is more recent years. Actually, I'm 73 now, and I'd say not until my 60s did I learn that I was the one who knew best how to manage my mental health. And I found that in my work with a trauma therapist. For the first time, I learned that it was more about what happened to me that was important if I wanted to get on with my life, and that I needed to focus away from what is wrong with me, which is probably what's wrong with everyone else if anything's wrong. And so I learned that because I started working with a trauma therapist and really learning more about why I did the things I did, might have done, why I was the way I was. And, and it was because of the things that happened to me, not because I was faulty or that I was this person that was broken and needed to be fixed, because I, was just, not as good at, or not normal and stuff. So, and then I learned about the term normal from people like other peers that were in the peer movement, some of my peers with lived experience who, in mental health experience, who told me that, who started talking to the state and the county about how we need to be our voice, and we needed to have choice, and we needed to have our human rights honored. And so I joined with them, and then that helped me being a part of that movement, and it helped me to personalize that and to see that I needed that, along with I found mental health professionals who also supported me in that. And they actually, for the first time, I had those who asked me what I wanted and how I wanted it and when I wanted it. And I wasn't, told how I was, because I was a certain diagnosis. This is the way you are, and this is what you do, and this is how we are going to control it. It was more like, where do you want to go from here? What do you want? How do you want us to help you to help yourself? And so I started doing things to manage my own mental health. Some of the things I did, I started doing, and most of them I hadn't even paid attention to before that, but I found things that were important to me in managing my mental health. I learned to make and keep my own appointments and choose who I wanted to see, when I wanted to see them, choose medications to take them or not take them, and to study them and see what really was the best for me. And at different times that was different. It was different what I needed, or what I felt I needed, what I felt would help. And I took time to be alone, time to be with others. I spent time dance. I learned to do things that were fun, like dance and water exercise and do jigsaw puzzles and listen to music and try to sing. And I just paid attention to, I tried to seek balance in my life, like with my rest, my sleep, my nutrition, and, managing chronic pain by myself, and just growing spiritually and trying to grow in every way I can. And so, and a lot of my help has come, my managing my mental health has come from helping others, such as what I think I do by serving on committees and groups in the community and interacting with people and trying to help them, to support them in getting their mental health needs met, which is their right and what they deserve, because they are human. They deserve.
Thank you. Julie, tell us your story.
Well, as an adolescent, probably around age 14, 15, I started having pretty severe mental illness problems. and I began being hospitalized, and was in the hospital system, psychiatric hospital system, throughout my teen years. And I was given the label of being mentally ill. I was turned over custody to the state. And at that point, I was alone. I had nobody supporting me. My parents were gone. And I was put on medications for reasons I had no explanation for. It was Haldol, Stelazine, Mellaril, those medications that caused me extreme akathisia. And
Can you
if
explain
I,
that term?
it caused me to be wanting to move uncontrollably, wanting to walk, having to move, not being able to sit down as a side effect. And if I complained, they just gave me more. And so I learned never to complain. And it also caused me to be unable to urinate. And those were not acceptable side effects, but there was nothing that I could do. And they also put me in the quiet room, which was a nice way of saying locking you up in solitary in a room with cement, with tile floors and pretty much cement walls, with one little window up there that you can't see out of, but lets a little light in. And you're in your hospital gown with a sheet. And you might be in there for a couple of days. And that isolation does have effect upon you. And so basically, I felt I was brought up that you earn your consequences in life. So I knew that I had to have done something wrong, something bad to have gotten here. And so I felt shame, and I felt that I was mentally ill. And eventually I got the wonderful label of borderline personality disorder. And that, and just not having any control over anything that happened to me, no control over my mental wellness, and having labels and all, began to identify who I was. And I was, at the core of me, my identity became, I am a patient. And when I eventually got out of the hospital, that identity stayed with me at the core, even when my symptoms subsided and I was able to go to school, be a parent, a single parent, get my degree, and work in the mental health field for almost 20 years. I was able to, I feel, be effective and do well. And I was satisfied with my life. But there was that black gnawing feeling of pain and shame, and always having to hide who I was, the true me. And that there was a little pain in that, but I was happy to have had that break. And then after some time, I started, excuse me, I'm getting dry mouth really badly from my medications.
Feel free to hydrate.
Thank you. About, I would say 10 years ago, I started having severe symptoms again. And I chose to go to a private psychiatrist because I didn't want people in the community who knew me as a provider to know that I was slipping. And so I eventually went up to Corvallis to go to the hospital, trying to hide out and try to still kind of have a job. And I went downhill quite fast, so I didn't worry about it anymore. And I started with the same routine of cycles of hospitalizations up to like 4 times a year for a month at a time. And obviously that was not working. And a lot of times it was suicide attempts or just overdoses that got me there. And I knew this is not working. And so I decided to leave the safety, even though going to this psychiatrist was not safe, obviously, that I could get that many medications saved up at once, but it was something that I knew. I decided to take the risk of going to another provider, a clinic that had a social drop-in center. And what I found was that drop-in center, that there were people like me who actually were sharing their stories, that they were happy, and that they were free to talk about anything that they wanted. They were laughing together, sharing tears together, and eventually I joined in, and I felt like I kind of had a role there in terms of helping others, and they helped me, and we played games together, and I felt like my feelings were validated and that I was a okay person, even though I shared my warts, that they knew about my past and all those things that I had hidden all those years, and that I was okay. And that black ball of shame and pain and all of that dissipated and gave me the freedom to be me. And it allowed me to have a voice and gave me the freedom to have choice and the power to start making and taking charge of my own mental health plan, so that I could work with peer supports and ask them for support and feedback on how to get from A to B. I could work on what did I want to work on right now in my life? Where did I want to go? And I found people and supports from people that respected me, that worked with me and listened to what I wanted and helped me move in the right direction. I found supports in the community and elsewhere because I learned to have my voice, to explain what I wanted, to be able to communicate and draw pictures, and to use community like Willamette Lane and elsewhere to put together a plan for me that evolves. So I've gone from a person who had everything happen to them to just recently, kind of like with TC, it's been just recently, and I'm in my 60s, to where now I have a voice and now I can take some control over my life. And I do work with other people in helping them find their voice and their power so that they have choices. And then I have the delight in seeing them pass that on to others. And it's quite exciting.
Thank you.
Mhm.
Amy, tell us your story.
Sure. So I was a pharmacist. I had worked retail and hospital. I worked in a psychiatric hospital in Pittsburgh where I ran patient medication groups with patients. I primarily worked with the young people that were in the hospital and also people who were suffering from schizophrenia. And I listened to what side effects they were having from their medication and talk to them about them. And then I also was part of the clinical care team. So I was able to write notes that went into the patient's chart so that the doctors and nurses knew. So unlike your experience, Julie, the voice of the patient was risen so that the doctor could better assess and provide better medication and outcomes. So I was fortunate to be a part of a hospital that ran a little differently. Then we moved to Wisconsin and I stopped working as a pharmacist to raise my family. And Marissa's younger sister lost her best friend to suicide in 2013. And there were several suicides in our community at that time. And I, along with the parents of Abby, Anna's friend, started a nonprofit called Red Gen, which advocates for youth mental health and well-being. And we have peer-to-peer groups in local middle and high schools that use a curriculum on emotional regulation and resilience skills. So I love your stories, TC and Julie. You're amazing women, and I think you share a lot of the journey of mental health, that it's a continuum, and sometimes medication is needed, sometimes it isn't. And we need to get used to talking about mental health like we do other illnesses. And just like people who have diabetes, they may be able to control it with diet and exercise, or they might need medication. Or so I think we need to look at mental health and give people the options to talk about it without feeling shame.
So let's have a conversation. So from your experience managing your mental health, what do you wish you had known earlier? Or what have you learned that you'd like to share with the group about managing your mental health?
Anyone?
I can call on people if you want.
Oh, well, I can say that what I wish I had known earlier was how helpful that socializing and finding someone like me, joining a group of people and not being by myself in getting well was. I would have done that 10 years ago or 15 years ago when I got ill the second time, immediately, if I had known. Because that would have given me another 10, 15 years of evolution. And in order to start helping others and maybe getting on committees and moving further along and hopefully helping the system change. And in terms of, of things that I would like to pass on to others is that message, is that having others to support you that are like you is really beneficial. I truly believe that. And that isolation whether it's staying in your house versus being in a quiet room. They've done studies. Even if you do it in your own home, still has kind of the same effect to your mental health overall.
But
And so-
probably differently designed.
Yes, very differently designed, but staying home and isolating and being like agoraphobic definitely sets you up to have a different outcome than helping yourself and working with someone to get out and being with people like yourself to learn your value and etc.
Others?
So as far as, I'm not sure which question that we were answering. What did you ask?
The question I asked was actually the third one in the sequence.
Okay.
Your experience managing your mental health, what do you wish you had known earlier? Or what have you learned since?
Well, what I wish I had known is that that it was okay to ask for help, and that mental, let's see, having a mental health diagnosis was not me, and that everybody actually, in my opinion, almost everybody could have a mental health diagnosis. And so therefore we're all in the same boat. So if I had known that, then I wouldn't have thought that these other people were authorities out of me and that they knew me so well, and that I wouldn't have designed my life according to what their wishes were, and according to their, and accepted some of the treatment that I did because I thought they had all these answers. I thought they were experts about me and what I needed to do to, kind of have some peace and comfort in my life. So I looked to them, I looked outward for that help where I could have been looking more inward, and where the help I was getting already to survive and to be resilient was coming from inside me anyway.
I think that's important to say, that a lot of the healing comes from not only isolating and going within, but also participating in the world. Yeah, I suppose I got triggered positively by some of your stories. So whenever I felt suicidal, I thought about my great-great-grandmother, who was the first African on, I'm African and Native. So she's the first African off the boat. And she made the Middle Passage at 4 years old. So I imagine a 4-year-old in a slave ship making a 3-month journey to here and then immediately being sold away from her mother. And she taught herself to read. And so I'm descended from slaves who taught themselves how to read when it was a death sentence. So we're going to read more. So I'm reading medical textbooks. So I'm understanding, okay, how do drugs work? And why do they think that we're crazy for wanting to be free and escaping slavery? And basically, as I grew up and got trained and got actual racists, clean and sober and less racist, I received death threats. Not from my clients, but from other racists who objected to my healing work. And so thinking about, okay, I'm feeling suicidal because I'm feeling hopelessness. Western psychology is not giving me any help. Should I take Prozac, or should I look at these feelings and focus on my life mission? and do the nurturing work that comes from inside, because I'm not getting validated from the larger society. And I looked within and formed a life mission of service and understanding, yes, sometimes I feel hopeless, but then what is the self-care? Listening to music, playing music, reading, getting out in nature, doing the healing work for self-healing that creates that balance.
Yes. Yeah, unfortunately, we do live and work and exist in a system where if you are, well, I'll just talk about myself being Black, then you do bring with you all of the, the experiences that you've had as, that has to do with racism, that has to do with being Black in America, that has to do with, for me, being female, being, so I bring all those things. I have all those things to, that have to become part, I have to consider in part of my healing. And they do exist. There are, racial disparities. There are, there's racism and prejudice. There's stigma to deal with for, because you have a mental health label, because you are Black, because you are female, because you are poor, because you are whatever, then there's all those, stereotypes, there's, stigma, there's prejudices and things that you have to deal with. And in a system where not everyone that you talk to is going to really be wanting, thinking of you first, or wanting what's to bring out of you what's best in you, and to be considering you as important as they are. A lot of healthcare professionals have not arrived there yet. Well, I wouldn't say a lot, but some have not arrived there yet. I think more are arriving at that position to see you as, to really see you and to see you as equally a part of the team of, and help you to help yourself, rather than to put things on you that they think is going to be best for you, or that they learned, but just to consider you as, a really important part of this, healing for you.
I think one of the things that Ali brought up, because she puts in the chat, let's not forget generational historical trauma is real. And also generational historical strength is even more real. Because to come up with that word in Aztec, if you could put that in the chat, Ali, of that talk therapist healer, right? So that's perfect, because even though Western psychology is, let's say, shall we say 100, it's younger than the United States, but there are cultures that are older than the United States that had modes of healing. And often to remember that is a source of great strength. Part of what was triggering for me, what Julie talked about, the quiet room. I'd made a trip to Africa to a slave fort, knowing that my great-great-grandmother must have passed through this particular building, and that what she described the quiet room, when Julie described the quiet room, that was the death room for slaves that acted up. And they were basically locked in this room with a single opening high up that admitted light and air, and they were left there to die. So I'm thinking, whoa, this is the same. This is the same. Wait, they're thinking that this is going to be healing. Why don't they have a healing garden that you can be alone in, or, not just bare tile? What kind of culture thinks that this is healing?
It was not a healing place to go. There was no healing. There was no healing. It was still in those days. It wasn't that far from the barbaric days in the state hospital at that time. They only had a few medications to choose from. it's kind of like keeping that history alive in some ways is important, to see how far we have come and to make sure that we don't end up there. But I know that it still exists and is happening. You know, it is. And it's under the disguise of the words quiet room and etc. But what I like what you're doing, and it seems to me what you are doing is that you are challenging you are challenging the value in etc. of Blackness, of the inequality and all for yourself and working it out. You can't change the whole world, but you're working it out for you in essence and bringing that out to others. Do you know what I'm saying?
Yes.
And presenting that to others in a way that you're drawing it in a picture so that others understand and can see the process of what you're saying and showing a difference. I mean, to me, it's fascinating. And I have something to compare it to, and it is a healing way of looking at things, what is possible. And that to me is a wonderful opportunity for other people to see and a way to get your message out.
Amy, I have this ongoing debate with my father, who's a psychiatrist. And many of the drugs that Julie mentioned, you know, when he talked, I said, well, my ethics as an SUD, you know, substance abuse disorder person and dealing with dual diagnosis, I can't argue someone from their medications if they're helping them, but pills are not skills. So I can't just manage my diabetes with insulin. I also have to exercise. I also have to meditate. I also have to employ other skills. And when Julie mentioned the drugs that she was talking about, that's like old school, old generation. There's newer substances and things like that, that are intended to at least provide stabilization. And you as a pharmacist, you know, again, you're to educate people on the purposes of medication in a way that's more accessible than the patient insert, which is usually what health providers just give you. Yeah, read this in medicalese, and you need a college degree to understand it. But they don't simply say, well, how is this helping with the diagnosis? Can you comment on that?
Yeah, I think that pharmacology and mental health is tricky. And I think it goes back to what Ali said, your provider is really important. It's really important that you have somebody that you feel open to communicate with because of the trickiness, because even the new agents, you know, can have some side effects that people are affected by. For example, you know, weight gain. Some people may gain weight and they don't like that, or, you know, maybe their palms are feeling sweaty or it's making them tired or whatever. There's still side effects. And so I think it's you always have to balance side effect with effect. And on top of that, some of these agents can take up to 6 weeks before you see the full benefit. So you're dealing often with the side effects before you're dealing with the benefit. And so it takes a lot of patience and fortitude and encouragement. And I also want to make another point that sometimes you need the medicine to help quiet down the symptoms too, in order to do the work, to do the behavioral work. Because sometimes, you know, people are so shut down, they can't even get to the therapist, right? And so, you know, I've seen a situation where sometimes a stimulant is added to an antidepressant to give somebody the ability to move forward, to do some of the behavioral work they have to do. And I think that open relationship is important, because sometimes there's traumas underneath the mental health symptoms that the provider needs to know about, because if you don't address that, no amount of medication or therapy is going to really get. You have to get at the root as well, because like you said, there can be comorbidity with negative coping, because let's face it, negative coping works. If it didn't, people wouldn't do it. It just causes you more issues in the long run. So it's, you know, people with mental health are the strongest people I know. They just are, because it takes fortitude and your voice and your choice. And so it is a process.
That's a great validation. Thank you for that.
Mhm.
Allie,
do
do
you-
you want, we don't often teach the skill of how the mind and emotions work. So medications that are prescribed to still intrusive thoughts, but we don't necessarily train people to use the breath to calm their minds. That isn't one of the skills that's actually taught. Would at some point, would you like to do the breathing piece and before we end, or how do you want to work that? Because the dialogue is still very rich.
Yeah, it's so rich. I would love if at 25 after we want to do that. But since you made that point, I was thinking about the question you asked the panel about sort of what do you wish you knew question. And one of the things I would love to share is that we are not our thoughts. And there are many different camps of, you know, how mental health professionals think about thinking and our cognition. But I am in the camp that we also can't control our thoughts, right? The brain is just a going. We have very little control over anything that it does, including the way it thinks sometimes. And we are not our thoughts. And sometimes it just gives us random wild thoughts that freak people out. Talk to somebody about those, right? And it doesn't mean there's anything wrong with you, right? Having those random thoughts. And I shared that with a client the other day, and I was sort of surprised by how impactful that was for them. Just that knowledge, that reminder that we are different than our thoughts, right? So having the thought, I'm a failure, doesn't make you a failure. It just means that you're having the thought that you are. Like, thank you, brain. That was so helpful, right? But at least our brain is working and being able to work with those unhelpful thoughts, right? Doing meditation, that's one way, talk therapy, being in community with each other. That I think is one of the most powerful ways.
I think it's often useful because yes, our brain has lots of thoughts. Some of those thoughts are not our own, particularly if you're a therapist developing empathy. And those thoughts, even though necessarily Western psychology doesn't believe in telepathy or whatever, but if I'm talking with a skinhead who the nurses have said, okay, when you see this guy, you need to get him into treatment. He's in DTs and apparently been sexually assaulted by whoever. And I'm talking with him, serving him green tea, and I suddenly start seeing images of jail. And so I ask him, where'd you do time? And he goes, how did you know I did time? I'm not going to answer that, but you're wearing a nice Thor's Hammer's wolf head, which probably means you're an Odinist brand of white supremacist, and you probably did time and had to join a gang because you couldn't join the Nation of Islam. You couldn't join the Mexican mafia in prison. So what does that leave you? Boom. And yes, it turned out to be correct. So that was a random thought, but it was a not so random thought. So sometimes honing that skill of empathy, knowing, this is my thought, or is this somebody else's thought, or is it just out there randomly? There is a way of calming yourself even with distressing material. Part of, can we talk about some of the things that we do for deeper self-care that can be incorporated in a culture developing mental health?
Who is that question to?
Anyone that feels the motivation to answer.
I'm not sure what you mean, so I won't take a stab at it.
What are your sources of inspiration that give you hope? TC.
Well, I'd say I guess I get hope from looking back in the past and see how things have changed in a lot of ways. You know, how we are moving. I mean, we're part of this group now where people from different backgrounds, different types of people are able to work together and try to make things better for all of us. And so that's a big change. And so I think just looking how far, you know, not how far we come, I hate that, but looking where I've been, where society has been, what changes have been made. You know, now we have, for instance, we have the peers are seen as being very valuable. The people who have the lived experience never were listened to. They never were put at the forefront of anything. And now we have a society where people are saying, wow, those people who have had different experiences, those are the ones to go to find out, you know, how, you know, what we need to do to improve things for them and for the world. And therefore, you know, they're the ones that have the answers. And so that is one of the biggest things that I look for, is those situations where I'm able to be a part of people who are saying, hey, you know, what are, you know, asking people what, you know, what has happened to you and, you know, where you want to go and, you know, and just help us to help you by telling us what, you know, you need to heal and to keep moving in your life and keep progressing. So.
Julie, what gives you inspiration?
What gives me inspiration partly is my gratitude to the peers, and some of them being so young. I mean, because I consider them young because I'm old. It's like I woke up in the last few years and found myself to be a senior, a grandma of 4, which is one of my very, very favorite roles in life. That's my passion. But I love to see these peers who are making such a tremendous difference, and all of the other people of older ages, like Drake Eubanks and David Oakes, and people who've been working all this time to change the system. But just to see all of the activity and the hard work of people of different fields coming together, trying to make change, not just mental health change, but change for all people who have been marginalized or whatever. come together and trying to make change for social justice and etc. That's what keeps me motivated and going.
Amy, what gives you inspiration?
Yeah, I think with the pandemic, it almost gave permission for people to talk more about mental health, and I get inspired by things like this, hearing all of your stories and seeing, you know, people need to see that side of mental health, need to see the strength and the lived experience. But I think getting at parity in mental health, where, you know, there's reimbursements at the same level for physical health and not separating mental health from physical health. And I would think the ACE study should help that because they are intrinsically linked. So I that gives me inspiration, knowing that more people are seeing it. And, you know, I think, you know, even if you look, the ACE study was in the 90s and it took to the, you know, into the 2000s, like 2013, 2014, before people really started to know about trauma. And I think there's hope in that. There's hope in the science starting to catch up, I guess.
Mm-hmm. And I think a lot of hope lies in that mental health is becoming known as something that is common to all. We all need to make mental health our priority. And we are all bothered. We all have some trauma. Some have, you know, some trauma in our lives, and so we are impacted by that. And so mental health, taking care of our mental health, is essential for not only for ourselves but for others around us. And as we get to more of an understanding of getting away from who's mentally ill and what to do with these mentally ill people, whereas to let's all look for everybody's mental health wellness. Let's try to create an atmosphere where all of us are able to get that mental health. You know, whether you're a mental health professional or whether you're a lawyer, doctor, whatever, you know, your mental health is important because you're impacting other people. You don't live in a vacuum. So your mental health is important and you need to take care of that. You have things affect you too. You know, you do have mental health to take care of. It's everyone's.
There's a question in the chat just before we go to meditation from Siobhan that I'll answer kind of quick and dirty. The question is, could you talk a little bit about how people who may be struggling with mental health can get relief? Well, all of us need to find a calm and a strength within that's catching. Because when people are in a mental health crisis, they're scared, and rightfully so. There is a motif, because I'm in the Southwest, in Navajo psychology, AKA mythology, the sacred twins, Monster Slayer and Born for Water. And so the Monster Slayer was basically the warrior with black obsidian armor that confronted the monsters and often was eaten by them. And then his brother, Born for Water, was the healer who, when the sacred smudge sticks started lighting themselves, that meant his brother was in danger. And so he prayed and instantly joined his brother inside in the belly of the beast, where the monsters were so consumed with rage, they couldn't see the way out. But him, with his healer's vision, could see the way out and guide them from within. And then the monster was slain, usually becoming a natural feature of the desert, or, you know, a sacred animal or something like that. So much of us, we have to have the courage to basically give calm and strength within. I must mention the 3 winners for the random drawing, Siobhan, Marianne, and Allison. Congratulations. Susan has your email addresses and she'll reach out to you. This says, let's see, Allie, why don't you take us out with the breath that unites us?
I sure will. And we will probably go past the 30-minute mark. So if you need to leave,
Yes.
please feel free. So I invite everybody to get into a comfortable position. If you're sitting, place both feet flat on the floor, resting your hands on your legs. You can close your eyes or look down at the floor. Allow yourself to have a gentle facial expression. And now, gently focus on your breathing. As you breathe, try to allow the air to come down into your diaphragm, just at the bottom of your rib cage, underneath your ribs. Feel your diaphragm move as you breathe in and out. Just notice your breathing and play an experiment with your breathing. Breathe a little faster or a little slower until you find a breathing pattern that for you seems to be your own soothing, comfortable rhythm. It's like you're checking in, linking up with the rhythm within your body that is soothing and calming to you. What you'll usually find is that your breathing is slightly slower and deeper than normal. The in-breath might be about 3 seconds. Hold, and then take 3 seconds for the out-breath. Ensure that the breaths in and out are smooth and even. Now you can spend some time, as long as you wish, just focusing on your breathing, noticing that breath coming down into the diaphragm, your diaphragm lifting, and then moving the air out through your nose. Sometimes it's useful to focus on the point just inside the nose where the air enters. So in through your mouth and out from your nose. In through your mouth and out through your nose. Just focus on that. Now we can just ground ourselves for a moment. So turn your attention to your body. Notice the weight of your body resting on the chair and floor underneath you, allowing yourself to feel held and supported, coming to rest in the present moment. Allow your mind to wander if that's what it wants to do. Be curious about where your mind wanders, and then gently guide your attention back to an awareness of your body as best you can. When you feel ready, slowly open your eyes and bring yourself back to the present moment. Sometimes it helps if you have a gentle stretch and a deep breath to prepare you to carry on with your day. Well, thank you all for another great webinar.
Thank our sponsors, Specific Source, Lane Community Health Council, Trillium, and the Trauma Healing Project. Next Saturday, we'll have the final webinar of this series. So we'll see you then.